Well, good afternoon, everyone. Oh, it's still morning. Good morning, everyone. This is great to have you come back for our Employer Oncology Roundtable discussion. We welcome you to our third and final workshop focused as part of our 2020 Cancer Care Symposium that started on September 24th with an overview keynote presentation by Dr. Pat Basu. And the focus is on building a comprehensive cancer care benefits strategy. So employers are searching for effective strategies to ensure access to high quality coordinated cancer care for their employees at an affordable cost. Employers also want to support their employees throughout the very difficult and very complex and stressful cancer care journey. And because of its complexity, we've divided the cancer care journey into 3 stages to make it a little bit easier for our employers to address the benefits designs for each stage. With workshop 1 focused on prevention and early diagnosis. Second was on cancer care coordination, and today's workshop focuses on benefit strategies to support employees in the 3rd critical stage of caregiving, survivorship, and return to work. Today's roundtable is actually coupled with a National Alliance employer roundtable on different modules, on the very same modules that we just talked about, the 3 stages of cancer care and of the cancer care journey. And so today we're going to have a joint program that I think you'll find very robust, very interesting, and also very productive for helping you figure out how to address cancer care in the workplace. Let's go to the next slide. Before we get started and I tell you how everything's going to roll out, I want to thank our sponsors for the entire Cancer Care Symposium. You can see them listed here. I won't go through them all, but for each of the workshops and the September 24th keynote presentation, we invited one of the sponsors or 2 of the sponsors to do a showcase. So what I wanted to do today before we start is our way to add value to their sponsorship and also to show our appreciation, to give them a chance to showcase what they do to help employers with their benefit strategies, particularly in the cancer care world. So we'll start with CareLoop, and Chris Sanders will talk about the CareLoop and their services. Chris, you want to go ahead?
Thanks, Marianne. Hey, everybody. My name is Chris Sanders. I'm the VP of Strategic Development of CareLoop. We are based in Dallas, Texas. We work all over the U.S., but we provide the world's first human-powered caregiver support platform, which helps working caregivers and their families plan for and manage the care of their loved ones. Yeah, thank you. One thing to really think about here is what actually is a caregiver. So a lot of people don't understand what that means, but a caregiver is an unpaid spouse, partner, family member, friend, neighbor who plays a critical role in helping a loved one with the day-to-day activities and medical tasks. So just keep that in mind as I show you a little bit here about CareLoop. One thing also, we are a family benefit. So whether it's I'm caring for my spouse with cancer, or maybe I'm caring for a parent or grandparent, there's so many benefits we have that focus just on whoever's on the health plan. We provide a service to help employees who are caring for anyone that they consider family. And again, that doesn't have to be on the health plan, doesn't have to be just a blood relative. You know, you could be caring for a friend, a neighbor, a roommate, domestic partner. You know, we are focusing on that employee who's caring for a loved one. The way that we assist these employees is we have a HIPAA compliant caregiver platform, which allows the entire family to come into one place to communicate and collaborate about the care of their loved one. But then the other side, the human side, we believe in caregiving, you have to have a human. So we help the family by assigning to them a care coach. And you'll hear from one of our care coaches today, Coach Julie. So we believe in the ability of using the technology side and the human side to help these families. So our care coach is there to be a concierge, if you will, to provide this white glove service to help families navigate through all the things they're having to deal with as caregivers. And lastly, just kind of to highlight some of the things that we're helping with. Most people associate caregiving as elder care and senior care, and it's not. Again, we help the family with everything. So whether that be, you know, a cancer diagnosis or finding nursing homes or understanding Medicare, Medicaid, a lot of COVID questions right now that are going on. You know, these are some of the things on the adult and elder care side we help with. And then the next slide here, we'll look at the pediatric side as well. Whether it's, again, a cancer diagnosis, maybe it's Down syndrome, infertility, adoption. One of the huge things I'm sure you guys are all hearing from your employees today is I need to find daycares, nannies, and babysitters. So we believe it doesn't have to be a diagnosis or a clinical issue. It could be just the day-to-day things of caring for your loved one. And that's how we help your employees care for whoever they consider family. So again, Chris Sanders, thank you for having us. We are happy to be a great supporter of DFW-BGH, and thank you all for being on today.
Thank you, Chris. We appreciate your support. Michael Hankinson is our field marketing leader and primary contact with Cigna, and he has a short video that he'd like to show to show what they're doing to help employers.
People say changing healthcare will take a moonshot. One company says, challenge accepted. Cigna, with new resources for physical and emotional well-being, advancing mental health with Talkspace, and making insulin more affordable for more people. Cigna is once again leading the way. So the future of healthcare may be a moonshot, but it isn't a long shot.
That was great. So now let's launch the program. Thank you to all of our sponsors again, and I know some of you are tuned in for this third workshop as well. A big thank you to the National Alliance of Healthcare Purchaser Coalitions. This is the national coalition group of all the coalitions around the country, including the Dallas-Fort Worth Business Group on Health. And they've brought to us this special program on 3 modules looking at the cancer care journey to give a chance for small groups of our employers to participate in an in-depth discussion on each of the 3 topics that we talked about, from prevention and early detection to the actual treatment, early diagnosis and treatment, and also today will be caregiving, survivorship, and return to work. We are going to have a report come out of the discussions that we've had with our small group of employers who have participated in each of these modules, separate from the workshops. Today, as I said, is a combined workshop with the module. And I think the results will be action briefs that the National Alliance will be putting together, which will share with all of the coalitions around the country. So we really appreciate this opportunity to be kind of the lead players in this, this initiative to really understand the cancer care journey from the employer's perspective and the benefit strategies that they have in place and what they could be doing maybe even better. So today's session will start with a presentation that is presented to us by the National Alliance that focuses on survivorship, surveillance, and return to work. This is the 3rd module. This presentation takes about 30 minutes, and we'll focus on several issues that we'll be talking about in our employer discussion after the presentation. Advanced care planning and palliative care and hospice care, survivorship and surveillance and return to work, payment reform and innovation, and impact of COVID-19 on your cancer care benefit strategies. I think you'll find it very, very interesting. Following the video presentation, we've invited Coach Julie Coates. She is one of Caroloop's care coaches. She comes to Caroloop as a continuation of a long career in social worker, serving primarily psychiatric and geriatric clients. And she has very well educated in this, in a bachelor's degree in social work and a doctor of jurisprudence as well. And in addition to all of her work in caregiving and her knowledge and experience in this very, very critical area of the cancer care journey, she also is a cancer survivor herself. So after the presentation, I'll invite Julie to talk about caregiving, the experience within the workplace, as well as her own experience. I think you'll really appreciate hearing her personal remarks as well. And then we'll have the roundtable discussion with 4 of our employers who have been participating in the other individual workshops. Teresa Williams with Elbit Systems. She's the director of Total Rewards. Rita White-Ross, she is a nurse with the City of Garland. She's the nurse health advocate, very active in our coalition. Rebecca McNeil, she is the director of benefits for Neiman Marcus Group. She is also our president of the Dallas-Fort Worth Business Group on Health. and then Joanne Hinton, who is Benefits Manager with the City of Fort Worth. So we'll come back to the discussion with Julie and with the our employer representatives. But first, let's start with the video. And I think you'll find it extremely productive and beneficial for your thinking about the cancer care, the third leg of the cancer care journey.
Hello, my name is Bill Rosenberg, and I'm an advisor to the National Alliance. I'm here today with Dr. Chuck Cutler to present the third and last module in the National Alliance's Oncology Initiative. Next slide, please. Today's presentation is about the end of the cancer patient's journey. That said, we're actually starting with advanced care planning that ideally should be taken before the journey begins, but typically is not. After a break for discussion of advanced care planning, we turn to what is fortunately an increasingly common situation for employers: survivorship, surveillance, and return to work. There will be a break after this section as well. Finally, we turn to two hot topics around cancer care: payment reform and the impact of COVID-19. Next slide, please. This slide is simply a reminder of where we've been and where we are today. The decks and recordings of modules 1 and 2 are accessible to coalitions on the National Alliance website, as will be this presentation. Next slide, please. Advanced care planning is making decisions about the health care a person would want to receive if facing a medical crisis and he or she is unable to communicate their wishes. An advanced care plan is highly personal and should reflect a person's goals, values, and preferences. There are 3 basic documents that we all should have on file, ideally much before they're needed. 1, an advance directive, which states the person's wishes regarding medical treatment. 2, a medical power of attorney, which designates another person, sometimes called a healthcare proxy, to make decisions if the person is not able to. And 3, a durable power of attorney, which allows a designated person to make financial transactions on the person's behalf. These are areas in which employers would want to avoid deep engagement, but they can provide valuable education and resources. Next slide, please. The major reason education is needed is that most employees do not have their advanced care plans in place. The studies mentioned on this slide indicate that 2/3 of those surveyed who were under 45 did not have advanced planning documents in place. And although the results were somewhat better for those over 45, 30 to 50% did not have at least one advanced care document in place. The survey also revealed widespread misconceptions at all ages about hospice and palliative care, topics that we'll get to shortly. On the right are some milestones suggested by the American Bar Association when individuals should re-examine their advanced care plan. I would add that the last item on that list, moving to a new residence, is important because the laws about advanced directives vary quite a bit by state. Next slide, please. In addition to state jurisdictions, there are many differences across individuals in how advanced care planning is approached. An Institute of Medicine report reviewed the literature regarding these variations and found that people differ based on their racial, cultural, religious, and other characteristics. For example, African Americans were found to be less likely than non-Hispanic whites to express treatment wishes or to have written advanced directives. Non-Hispanic Protestants and Catholics tended to prefer cessation of medical treatment when their condition is incurable and causes a lot of pain, while Black Protestants and Hispanic Catholics would tell their physician to do everything possible to save their lives. Cancer patients in the United States wanted to find out about their diagnosis alone, whereas Japanese patients were more likely to want to have a relative present during such conversations. Finally, a study found that Latinos in LA had strong preferences regarding their care, but about half of them had never discussed these preferences with their family or physicians. Employers should keep these differences in mind when they consider how to address advanced care planning with their workforce. Next slide, please. We see the employer's role in advanced care planning as twofold. First, raising awareness of its value, and second, identifying available resources for assistance. This role can be fulfilled via HR or EAP, or via referral to organizations such as those listed on the right-hand side of this slide, or through local resources such as PCPs, local hospitals, attorneys, and consumer organizations. Next slide, please. As with advanced care planning, employees can benefit from education about palliative care and hospice care. More importantly, employers can provide tangible enhancements to the patient experience by covering palliative and hospice care in their benefit plans. These services improve the quality of life by mitigating pain and other symptoms often associated with cancer. They also provide support to caregivers, for example, by covering brief in-facility stays or as respites from the stress of caring for a family member. There is some evidence that these programs can also improve value by mitigating costs. Education about palliative care and hospice care not only should identify their value, but also their four major differences. Hospice care presupposes certification by a physician of a limited life expectancy, and palliative care does not. Next, palliative care does not give up the curative intent of care, and hospice does not provide curative services. Third, hospice care does not include curative treatments, but it does provide strong coordination for all of the services that it does provide. And finally, while there are more or less standard hospice benefits, the definition of palliative care benefits in practice is less concrete. Next slide, please. Hospice benefit descriptions often mirror Medicare's hospice benefit, shown on the right, though they may impose limits on the number of days covered. Health plans typically negotiate per diem contracts with hospice care providers as a percentage of Medicare. And of note, on the list of hospice benefits to the right are homemaker services and short-term respite care, the former to help the patient stay at home, and the latter to give the patient's caregiver some time off by admitting the patient to a facility. The story for palliative care is different, both for Medicare and private health plans. There is no palliative care benefit per se. Rather, for Medicare patients, the services that make up palliative care are basically bundles of services that are covered individually. While we haven't seen studies of this pertaining to private health insurance, our sense is that the same is true there. In other words, health plans cover individual services that may constitute palliative care, but typically do not cover a specific palliative care benefit per se. Next slide, please. Palliative and hospice care can improve the quality of life for patients and provide support for caregivers by managing physical and mental symptoms, providing information and support to family and patients, avoiding hospitalizations with a nurse available 24/7, and making bereavement supports available to families. Of course, entering a hospice program is a tremendously difficult decision. Not surprisingly, the data show that a high percentage of patients tend to defer the decision until days, not weeks or months, before death. Next slide. Beyond educating their employees about palliative and hospice care benefits, employers should work with their health plans to make sure that these benefits are available and on an in-network basis. Particular attention should be given to how palliative care is covered, whether as a formal benefit or as bundles of services. This is important because patients receiving palliative care benefits are more likely to enroll in hospice care on a timely basis, and enrollment in hospice care can lead to increased quality of life and lower cost. To monitor the impact of this strategy, employers should require their health plans to collect data on hospice care utilization. Ideally, the data should show few ER visits near the end of life and a trend of lengthening stays in hospice care. The 25 to 30% growth of survivorship is increasing the number of cancer survivors returning to work and the demands on employers to accommodate those individuals. In the first two modules of this series, we've emphasized the need cancer patients have for psychosocial, navigational, and other support throughout the patient journey. In this section, our focus turns to the support employees at work need if they have completed active treatment or are providing care to another person. Next slide, please. EAPs are one source of the services needed, whether for employees or employers. Some of the services needed include training about cancer patient journey, from prevention and screening to return to work, and benefit availability throughout the journey. The latter would include awareness of disability coverage during treatment and support and accommodations after return to work. Intake and referral services, including identification and referral to psychosocial, navigational, financial, or other support services, and access to centers of excellence or hospice if the need arises. Another service would be support for employees and families when challenging cases arise. And finally, helping managers address cancer patients' needs when they return to work. Current experience is that EAP services are often underutilized or insufficient. In some cases, employer organizations like the Florida Alliance for Healthcare Value have partnered with community organizations to create programs to fill the gaps. In others, employers can look to widely available advocacy organizations like the Cancer Support Community. Next slide, please. One area where support can help is with respect to surveillance. This slide shows a breakdown of the increases in survivorship I mentioned at the outset, and it's interesting to observe that a significant amount of the projected increase is likely the result of the preventive and screening measures that have been emphasized. Almost 50% of the projected increases in survivorship for men and women are for prostate and breast cancer, respectively. As more and more of these cancer patients return to work, it's important for employers to remember that they often have just finished a grueling course of treatment and that they can experience significant stress around their periodic surveillance visits. Next slide, please. Last year, the National Alliance participated in a study with the Patient-Centered Outcomes Research Institute, PCORI, that found that an increased frequency of surveillance offered limited value for colorectal cancer survivors. Employers can help employees mitigate unnecessary stress by encouraging dialogue with their employers with their providers about goals of surveillance and follow-up care noted here, management of treatment-associated toxicity, health promotion and secondary prevention, and psychosocial well-being. Next slide, please. Increasing survivorship can also increase the demands on employees who are caregivers. Most employers are keenly aware of the flexibility and accommodations employees undergoing treatment need, but the emerging impact of caregiving on employees and employers can easily be overlooked. When the employee is a caregiver for a cancer patient, they often need accommodations at work similar to those that employees undergoing treatment require. They may need to telecommute, use sick or flex time, or other paid or unpaid time off to fulfill their caregiving obligations. Employers should consider this impact of the cancer patient journey on their organizations and communicate the support and resources available. For example, educational resources, including those about financial support, care coordination services, and the array of benefits available. Next slide, please. Employers should plan for inevitable increases in cancer survivorship. Without directly intervening in employees' personal matters, they should develop and communicate the support services that are available for employees who are cancer survivors and for those who are cancer caregivers. They should encourage cancer survivors to question their doctors about the evidence underlying the surveillance protocols with which they're being asked to comply, and they should encourage survivorship planning. For example, by making available professionally developed tools for survivorship planning, such as the two examples noted here, one from the University of Pennsylvania and the other from the American Society of Clinical Oncology. Next slide, please.
I'm Dr. Chuck Cutler, and as Bill Rosenberg, I'm also an advisor to the National Alliance, and I'll be continuing the presentation. I hope by this time of the presentation, you have gotten the idea that cancer is not one condition, but a diverse group of conditions. And it's actually gotten more complex over the last few years with the recognition of biomarkers and other markers of cancers that allows even finer diagnosis and more targeted therapies. All of these things, however, pose a challenge to payment reform, and so progress over the last few years has been slow. There are a variety of reasons for this. One is, while we think of cancer as being fairly common, even the most common cancer, such as breast cancer, only has about 280,000 cases a year in the United States. This means it's about 1 per every 1,100 people, so that even if you're a reasonably large employer with 100,000 employees, that means you only have 100 people in your population that has breast cancer. And within that population, the severity of the disease can vary markedly. We know that with early diagnosis, and we hope that there are more early diagnoses, that the severity of the illness and the opportunity for cure is much less. So that someone who has breast cancer identified early on mammography with carcinoma in situ has a very good prognosis without a lot of extensive therapy, whereas someone who has stage 4 disease will have much more extensive and expensive therapies with much poorer outcome. The prevalence of any specific cancer in a population is relatively small. So depending on your population, if you have a relatively young population, you may not see much prostate cancer. If you have an older population, you would more likely do that. But even with that, the population with cancer is relatively small. The prognosis and the individual therapies have to be targeted to the patient's underlying risks and other conditions. People with diabetes or heart disease or lung disease or liver disease obviously are going to be treated differently from people who are otherwise healthy. In the past few years, the development of biomarkers allows specific therapies to be targeted. The good news is that many of these therapies can have fewer side effects than the traditional chemotherapy and produce better outcomes. On the other hand, they're used in an increasingly smaller percentage of patients. The more targeted they get, the smaller the group of people who they will affect. Finally, a diagnosis of cancer raises emotional concerns among many people who want the most flexibility possible in terms of choosing their treatment center and treating physicians. So this makes managing volume commitments to a specific center much more difficult and challenging. So overall, the incidence, the variation in treatment, the need to have a fairly wide network makes the traditional methods such as bundled payment or capitation much more challenging and frequently just unworkable. Next slide, please. There is an experiment currently being done by Medicare called the Oncology payment model. It was begun in 2016, and it's a 5-year study based on the Medicare fee-for-service program. It requires that the providers add a series of functions, many of which we've recommended in this and previous modules. They include patient navigation, access 24 hours a day, 7 days a week to an appropriate clinician who has access to the patient's record and can make recommendations. The treatments need to follow therapies consistent with the nationally recognized guidelines, and the treatment plan needs to contain the 13 components recommended in the Institute of Medicine study called Delivering High Quality Cancer Care. There are quality standards which are part of the program, and all of these are reviewed retrospectively in order to decide whether the practices are eligible for a targeted payment. So far, though, the results have been fairly disappointing. Next slide, please. From the financial perspective, there's been no significant effect on the overall payment in the fee-for-service system. With that, there's a net loss to Medicare when the payments for enhanced services are included. There's been no increase in efficiency. On the other hand, one of the good aspects of the program is there's also been no reductions in the use of novel treatments. On the quality side, there have been improvements in a number of the areas which we find important. So there's been an increased coordination with 24/7 access. There is expanded financial counseling available to patients and their families, but there's been no change in emergency room visits or hospital admissions, and no change, or a minimal change, I should say, a 1% change in decreased hospital admissions at the end of life. So the bottom line is that there's little evidence that the OPM is driving value-oriented interventions. There are still 2 years left in the study. We may learn more going forward, but so far it hasn't shown the kinds of change we would like to see. Next slide, please. The initial steps taken so far that have been successful are not related to the methods that we just talked about in terms of bundle payment or capitation, but there are some opportunities. The first opportunity is bundling the chemotherapy costs to include all of the various aspects of chemotherapy. So that should include the drug, the infusion, administration, and the site of care. There have been some abuses in the past in terms of marking up the cost of the drugs or the administration or the site of service. So the more these can be bundled together for the specific chemotherapy regimens, the more control there is over the costs. There are some initial efforts also about value-based pharmacy, especially for the newer higher cost drugs, the biomarker drugs. Many of these can cost in the range of a few $100,000. And there is one experiment, again, being done by Medicare with a drug that can cost as much as $1 million, where Medicare only pays if the drug produces the desired result in the first month. Now, there are some challenges to doing this, not the least of which are the regulations around the best price that Medicare gets and the effect of potential rebates on the best price. But there are some experiments there which we should be learning from over the next few years. There is an opportunity to steer patients to those places that use lower cost centers, such as outpatient infusions or even home infusions where it's appropriate. And there have been some efforts to identify the high value providers who adhere to the standard guidelines, use the most efficient settings, provide care navigation and support, and comprehensive support for patients and their families. The oncology patient-centered medical homes, while still early in development, are another potential opportunity. Next slide, please. COVID-19 has had an effect on the entire cancer patient journey, from prevention through clinical trials. It's affected each of the different areas, and we're going to talk now about each of those areas individually. Next slide, please. In terms of prevention, it's been a bit of a mixed bag. Social isolation has given people more time to take advantage of education and to try to change their habits. In fact, some people would suggest that the pervasive effect that COVID-19 has had on all of us has unfrozen us from our habits and given us the opportunity to make changes for the better. People taking advantage of online learning about diet and exercise, for example, maybe changing their habits in ways that will decrease their risk for cancer. The folks who are exercising outside, if only to take advantage of getting outside to be free of their apartments, are getting a positive effect, and that can help decrease their risk for cancer as well. On the other hand, the isolation and stress has the opportunity to increase risky behaviors. People staying at home may be smoking more or increasing alcohol or other substances. People have the opportunity to make healthy food choices, especially if they're cooking for themselves. If they're buying healthy foods and learning how to cook more healthily, that'd be great, and it could decrease the risk of some cancers. On the other hand, for those people who aren't doing that and are ordering foods, either prepared foods or foods from restaurants, may be getting a diet that's higher in fat and salt and other risky components. And again, exercise has been wonderful. And during the summer, when the rates of COVID was relatively low and it was good to be outdoors, we saw some increase in exercise, but it's not clear how that's going to continue in the fall and winter, especially now in October, November, when the case rates are high and the weather is not so good. Next slide, please. In terms of screening, it's been really challenging to continue screening at the rate that we had been doing it previously. In fact, the Surgeon General advised hospitals and ambulatory care centers to delay non-urgent procedures such as colonoscopy. In fact, gastroenterologists in some parts of the country where there's been a rapid increase in the number of cases have been recruited as part of an all hands on deck strategy to take care of patients in the hospital with COVID, or to free up others who are more expert in caring for COVID patients to do so. So colon cancer screening has been deferred. People have been reluctant to go for other routine visits such as mammography, skin exams, or pap smears. Data from EPIC, the electronic medical record system, notes that screening may be down in the range of 85 to 95%. Now, it is worth noting that the screening schedules for cancer are at best most frequent, that is to say, on an annual basis, with many being much less frequent. So the recommendations for colon cancer screening, for example, are every 5 to 10 years, depending on risk. So there is an opportunity to catch up over time. But in the meantime, cancer risk screening rates are down, and that probably will lead to delays in early diagnosis for some people. Next slide, please. In terms of treatment, there are a number of barriers to treatment for people during the COVID pandemic. Current or past patients with cancer have or can have impaired immune responses. It can cause them to have a higher complication rate and to be able to fight off the coronavirus less well. The treatments, especially chemotherapy and radiation therapy, have an effect on the immune response. Many of the treatments cannot be done with social distancing. They require being hooked up to an IV or an infusion, or being positioned for appropriate radiation therapy or for surgery. So all of these things require that people get face-to-face care. The priority of care for COVID patients also may have pushed some cancer patients further down the list. So for those people who can wait for their cancer treatment, especially in situations like March and April in the Northeast and October, November in the Midwest and West, where there are limited availability of beds, operating rooms, ventilators, personal protective equipment, it may be difficult for people to get access to care in those facilities. Next slide, please. Not all cancers pose the same risk, and a number of the specialty societies have come up with recommendations based on the particular type of cancer. So some treatments can be delayed. For example, slow-growing prostate cancers can be delayed for a few months with very low risk. On the other hand, aggressive cancers, leukemias, for example, need to be treated much more acutely, and the specialty societies have made some recommendations around this. In addition, we need to take into context the current ambient issues where COVID may be more or less prevalent. Where in the course of the epidemic is the individual location? Are there beds available to treat people for COVID and not available to treat people for other conditions? Is there adequate PPE available, et cetera? And all of this is factoring into the consideration around treatment. Next slide, please. We know that treatment has been impaired. We know from a case study in the Netherlands of 5,000 people that over 30% reported consequences related to their oncology treatment or follow-up. The most common was the switch from in-person visits to video visits, and these visits actually have been quite successful. The most important adjusted treatments were those for chemotherapy and immunotherapy, and those require in-person treatments, again, which can themselves cause increased risk to individuals. This kind of discontinuation caused people to be very concerned about the consequences, and they may well suffer some consequences due to the delayed treatment. Next slide, please. A modeling study from the UK published in The Lancet shows that looking at 32,000 people, their types of cancer, their treatment, and developing 3 scenarios comparing pre-pandemic and potentially post-pandemic mortality, shows that for common cancers such as breast cancer, the increase in deaths over the next 5 years could be as great as nearly 10%, with some of the other cancers having a somewhat lower but still increased death rate just due to the interruptions of screening and treatment. Next slide, please. Clinical trials require adherence to a specific protocol, and the protocol often requires that people be seen in person. Recruitment also can be better achieved as an in-person process. But as part of the clinical trial, people need to have a physical examination, they need blood tests, they often need imaging studies, and all of these need to happen in person. So when people are concerned about exposure to COVID-19 and are at risk for exposure and complications, recruitment to clinical trials have been severely constrained. In addition, once in a clinical trial, once someone's enrolled, they need to adhere to a tight schedule for monitoring. This is both to evaluate the efficacy, but also the safety of new drugs. So all of these things are being challenged in the current environment. Next slide, please. Can we make any lemonade out of the lemon of the COVID-19 pandemic? Well, there are some things which have improved by necessity during this time period. One is the increased use of telemedicine and video visits. Oncologists, I think, traditionally have been loath to use video visits. They like seeing patients in person, and often it's important to do so. But under pressure, there are many visits which actually can be accomplished equally effectively using telemedicine. So follow-up visits, for example, review of previous testing, evaluation of symptoms, and even visual inspection of masses can be done using telemedicine. The testing and imaging and blood tests obviously need to be done in person, but they can be done with limited risk than being in a clinic with a large number of people. The risk stratification assessment and even treatment planning can be done virtually, and tumor boards can meet virtually and have done so. There have been some early attempts to use home infusions for drugs which can safely be administered at home. While there are some concerns about doing that for some drugs, it's a possibility and may be increased in the future. Next slide, please. We're going to pause now to allow you to discuss the impact of COVID-19 on cancer and cancer care. But before we do that, we'd like to thank you for your participation in this program. We would like you to review the highlights of the curriculum and the action steps. For those of you who haven't had the opportunity to review modules 1 and 2, those will be available on the National Alliance website. Action briefs will be available in early December 2020, also for each of the modules, and we look forward to your feedback. And now please take a few minutes to discuss the impact of COVID-19 on cancer care. Thank you.
Very good. That was excellent, an excellent presentation, an awful lot of content to chew on for all of us. But again, this recording and the presentation will be available to those who are participating in this roundtable discussion in this workshop today. So don't worry about having to memorize or write everything down, because you will have access to this. It's very comprehensive. We can talk about the impact of COVID-19, and but we'll start into that. But first, I'd like to reintroduce Julie Coates. She is the coach with Caraloop, and she, as I said, she is a very experienced caregiver and can talk about the caregiving side of this discussion in this workshop and and oncology module. And Julie, as I said, is a cancer survivor and willing to share some of those experiences from the real patient point of view. And one of the things before you start, Julie, I just wanted to mention something that just kind of blew me away, that 70% of working Americans are burdened with caregiving responsibilities. Now, this is not all for cancer care patients, family members, but it's also for all of the other things, the child care and children at home trying to study at home rather than in school. COVID has had a dramatic impact on that, and just a host of other reasons why people, working Americans being burdened with the caregiving role. So Julie, tell us a little bit about it from your perspective as a professional and as a personal experience.
Okay, thank you, Marianne. Thanks everybody for being here and letting me share some of my experience. I have to set the timer because talking about caregiving and myself is one of my favorite things to do, so I get carried away sometimes. As Marianne said, my name is Julie Coates. I'm a social worker by training and years of experience in healthcare in various settings. Been with CareLoop since 2016, which ironically was exactly when I was diagnosed with my ovarian cancer. In fact, CareLoop gave me a job while I was in the middle of treatment. And so I love to share that because it's so important to me and I will never be able to pay them back for that. It was so generous. One of the maybe less helpful things I'm going to say is that every caregiver situation is different and every cancer situation is different. So I can't give you a hard and fast set of rules or guidelines or do's or don'ts because that just doesn't actually exist. And so what that means is that the emphasis needs to be on communication, whether you're the caregiver or the person with cancer. Because the other part of this is that nobody teaches you how to be a caregiver. There's not a class in school. There's not a sit down talk with your parents where folks explain to you how it works and what you're going to need to know and what you're going to need to do. That doesn't happen. And so frequently caregivers, especially new caregivers, are very panicked when we come into their lives. They have no idea what to do and they don't know how this works. And so just having a care coach on the journey with them sometimes is really the most important thing. The other thing is that caregiving is by and large a thankless job. You know, you get an occasional thanks every now and then when you provide a physical task assistance for somebody, but you know, you're not getting a big thank you at the end of every day, and yet you are exhausted from caregiving at the end of every day. So it's not necessarily a very rewarding situation to be in. It's also not that uncommon for us to run across a situation where a person is caregiving for somebody that they didn't like very much during their lives, and they have, you know, complicated emotional terrain where there are lifelong resentments and anger and fear. And so there's a lot of that sometimes that comes into play as caregivers roles shift because frequently that was a person who was a caregiver for you when you were younger and now you're the caregiver for them. So that can come with some very intense problems as far as emotional relationships and caregiving. We do find folks who need a lot of hands-on physical assistance with the day-to-day caregiving for folks with cancer. As I said, it's different for everyone. So you don't know whether, you know, some folks are going to have chemo once a month. Some people are going to have chemo every day. Some people are going to have radiation 5 days a week, but not on the weekends. And so there's some very specific problems that come along with that. One of the most common of which is transportation. You know, Medicare, Medicaid, insurance, nobody covers transportation to and from chemo. And or radiation, if you're getting radiation 5 days a week, that's expensive if you want to take an Uber or a cab. And so that's a very common issue among caregivers and cancer patients. And also in the same vein, there's very little financial assistance available to help with copays and the costs of treating side effects, things like that. There's a few organizations that are specific to one type of cancer or another who have some funds available to do that, but having cancer is very expensive. You know, I did the math on mine, and my overall cancer treatment start to finish cost about $100,000. And of course, I didn't pay very much of that at all. I had good insurance, which was just the grace of God or luck, whatever you want to call it. So I didn't have a lot of financial burden as a result of my cancer, but most people do. What if you're the primary breadwinner for your family? And so now you're, as a caregiver, you're expected to provide financially when that wasn't originally your role, and you've got to be a caregiver at the same time. So that can be really overwhelming. And there's not very much financial assistance out there, but we will get out there as a care coach and dig until we find something that might help you, you know, with the financial costs of caregiving and being a cancer patient. Another thing that is a burden as far as being a cancer patient or a caregiver is that sometimes you're really sick while you're getting treatment, whether that's radiation, chemo, surgery, whatever. And just having cancer is not, the diagnosis of having cancer is not enough to keep you in the hospital. It's not enough for you to be admitted to a skilled nursing facility. That doesn't qualify you for any type of care except the actual medical treatment of your disease. But the side effects of your disease, that doesn't qualify you for any care at all. Medicare doesn't cover that. Medicaid doesn't cover that. Insurance doesn't cover that. I remember having a gal who had a new cancer diagnosis, which had happened while she was in the hospital for something else. And her niece was my member who had a care loop as a benefit, and her aunt had nowhere to go. She was too sick to go home. She literally could not be at home by herself. She was too sick. She couldn't go to a nursing home. Just being sick from, you know, having side effects from your cancer treatment is not a good enough reason to go to a nursing home. It doesn't qualify you to stay in the medical hospital. So that was a huge challenge for us, finding either a facility she could go to that she could afford to pay for out of pocket, or setting up in-home care somewhere that she also was going to have to pay for out of pocket. So that's a lot to deal with, whether you're the caregiver or the person with cancer. That's a lot. There's also legal problems that come along with having cancer. Of course, there are those related to work, which is what we're talking about here. But, you know, maybe you're getting diagnosed with cancer while you're in the middle of a divorce or in the middle of a custody battle. And so that kind of thing comes up kind of more often than you think. And we as care coaches are going to try to help you with that part as well. Because that goes back to the fact that every cancer case is different. Every caregiving situation is different. Some people, you know, can tell you exactly what they need. Others don't even know what they need when you meet them. And that's where that communication comes in again. So it really hinges on communication all along the path, whether that's at work or at home or at the hospital. So one of the most important things you can do for a cancer patient and a cancer caregiver is ask them what they need help with. And not just, you know, hey, let me know if you need anything, but how are you doing financially? Do you need help with transportation? Do you need people to cook meals and come by or check on the person with cancer at lunchtime, or get a Meals on Wheels, all those kinds of things. It's easy to say, you know, let me know if you need anything. And I've said that to many people, and I meant it. But oftentimes when you're the patient, you A, either don't know what you need, or B, you're not thinking clearly enough to let somebody know ahead of time that you might need help with something. One of the other side effects of cancer treatment is brain fog that comes with chemo, that comes after many types of treatment. And so it's a lot to ask that cancer patient to think ahead of time for a couple of weeks and let me know everything that you're going to need. So sometimes it's easier for everybody to ask a specific question. Okay, do you need any help with transportation? Do you need rides to chemo? Do you have food at your house? Do you have somebody that can help you get up and go to the bathroom if you need to go, or get up and take a bath? And sometimes it's easier for a patient and a caregiver to answer those more specific questions. There's a host of things that are affected by both cancer and caregiving. And there's too many to go into one-on-one. But one thing I do want to point out is that for both caregivers and patients, there are a lot of apps that are available that can help you manage things. There's apps for scheduling chemo rides and scheduling meal delivery and all those kinds of things, as well as some of the more touchy-feely aspects of caregiving, just or cancer, feeling like you're not alone, because that is one of the things that happens when you're a caregiver is, like I said, you don't get a lot of thanks, and yet people are real good about checking on you in the beginning, but 3 or 4 months into treatment, you're not getting all that emotional support and those people who are coming by to bring meals and see how you're doing. So one of the other things that I like to tell people when they are caregivers, as well as cancer patients, is you can't get it wrong. Okay, people are very scared about getting things wrong when they're caregiving. And what if I do it wrong? What if I make the wrong decision? And there is no track record. There's no map available. You know, so you can't get this wrong. And that's one of the things we can walk through with you as a care coach, is that if we do something and it doesn't work out well for the patient, then we'll do something different and we'll make adjustments. And if we made a mess, we'll clean it up. But you can't get it wrong. And so sometimes people just need to hear that. So that's pretty much what I had to cover. I will be happy. I'll be available for questions later or anytime. I want to thank you guys for letting me speak, and I look forward to talking with you more.
Thank
Thanks,
you so much, Julie. That was really, really helpful. I appreciate it. I took a bunch of little notes here about what you were saying. And I just think that what you were discussing is so important about all of the issues, the communications, and patients may know or not know what they need, and just to take all those things into consideration. And then for the little assistance with co-pays or just the cost of taking care of side effects. I mean, nobody even thinks about those things. So this was really helpful. It kind of puts the whole perspective of the role of the caregiver, and sometimes perhaps even the caregiver, him or herself, is also on the cancer care journey. So life is complicated for people suffering in that way. And employers have opportunities to help support their employees in either role or in both roles as caregiver and or patient. So now what I'd like to do is turn to our employer roundtable discussion. And I'm so pleased to have with us for this discussion is Rita White-Ross with the City of Garland. Thank you, Rita. You're a trooper. You've been through all of our modules and workshops, so really appreciate your participation. And same with Joanne Hinton with City of Fort Worth, has been a regular for all of our 3 modules and on oncology, the roundtable discussions and the workshops. Rebecca McNeil, so pleased that you could take time out today, and I know what's going on over at Neiman's. It's not easy for you either, so thank you for participating in today's discussion as well. Teresa Williams with Elbit, she has been a regular participant in our roundtable discussions also. And I'm also really pleased to welcome Julie Tatum. She's the benefits director for Whataburger in San Antonio. She also serves on the Texas Business Group on Health. She's got a busy load right now and maybe in and out of this discussion, but thank you for being part of this, Julie, and taking time out. And then Tynita Morris is the director of benefits with Greyhound, and she serves on our board of directors, the Dallas-Fort Worth Business Group Board of Directors on the Executive Committee. And Tynita, it's always a pleasure to have you join in because you always bring a richness to our discussions. We also have a visitor, Ashley Tate Finger with the Florida Coalition. The Florida Coalition is one of the other few coalitions that were invited to participate in the cancer care oncology roundtables through the National Alliance. So thank you for joining us for this as well. Feel free to join in the discussion if you'd like to, or listen in. Okay, so let's turn to the discussion. The first one shown here on the screen that we left up from the presentation by Chuck Cutler and Bill Rosenberg is on the impact of COVID-19. It's on everyone's mind, and so we just can't get away from it, and it just keeps on resurging, and it's impacting everything. And when it impacts the cancer care strategies that employers are putting in place and their employees suffering from cancer, we've got a double whammy here. So just thinking about this from our employer perspectives, let's think about the COVID, the impact on your cancer care benefits strategy. So, for example, anyone want to jump in? Rita, how is it? What about your employees' access to care at city of Garland, do you find that are they using telehealth more, or all employees need care, but what about the cancer patients? Can you comment on that?
We did move from primary care to telehealth and urgent care because we were trying to avoid, where we could have people schedule an appointment so they could just call us say, I need a COVID test or have these symptoms, and we just have them come in. Mm-hmm. So that's the one thing that we changed our model is to more telehealth and urgent care.
Mm-hmm. That's helpful, and the access to care, the telehealth is kind of like a godsend during COVID for people who are afraid to go to the doctor's office or maybe thinking of delaying care. But for a cancer patient, the early detection is critical, as well as the actual access to the treatment. And it's hard to be COVID compliant when you are a cancer patient trying to be socially distant and having to go to a treatment center, whether it's in a hospital treatment center, infusion center, or the physician's office. And thankfully, you can also do it at home. We talked about site of care as being important, especially in the cost management side of it, choosing a less expensive site of care. So anyone else have any comments about the access and the challenges that the employees face when they're trying to be COVID compliant? Teresa, with Williams with Albert, have you seen any challenges that you're aware of in your cancer care population? I'm just calling on all of you randomly just to get your thoughts on this.
Well, for the city, we did adopt that CARES Act that said, part of the CARES Act that said, we opted to cover, I think actually this was not CARES Act, we opted to cover virtual visits at 100% for our health center plan. And our health centers, which are run through THR, Texas Health Resources, were able to accommodate or adapt fairly quickly in that they started offering their own virtual visits with our health center providers. So our employees are still getting the continuity of care by being able to talk to their general provider, the same one that they would see in person, but they're able to do it as a virtual visit or telehealth. And then, again, because we have this great partnership with Texas Health Resources, we were at one point about to go into setting up our own rapid testing site. I think we ultimately ended up dropping that just because the availability of testing at the time was still so limited that they weren't able to get it for a lot of people, let alone for us. So we didn't get to do that piece of things, but they would refer to folks to testing facilities that did have tests when a person with a COVID symptoms came up on the telehealth visits.
Yeah, interesting. Well, thinking about some of the issues that were discussed in during the presentation and what Julie discussed, Julie Coates, as a caregiving, as I mentioned, 70% of working Americans are burdened with caregiving responsibility. How about some of the companies, for example, Rebecca, with Neiman Marcus, how are your benefits supporting caregiving responsibilities? Do you have anything in place specifically for caregiving?
Yeah, I mean, it's interesting because, with the pandemic, in our situation, like a lot of other situations, a lot of other employers, we had a lot of furloughs. And so a lot of our associates, they were just, because we had no work for them, they, if they either had caregiving needs themselves or, had family members that needed caregiving, they were, able to do that just because they didn't have a job to go back to. But we've also had a lot of associates take advantage of the different local, state, city, local leave laws to take care of family members. So that's, you know, and we have a pretty generous sick leave policy, as well as we're very flexible with just our associates taking leaves of absence in general. So we tend to let people, you know, rework their schedule. I mean, being in retail, we have the, you know, a little more flexibility to be able to work with our associates if they need, you know, time off during the week, during the day for doctor's appointments. So it is easier for us to accommodate, but we definitely, we don't have anything sort of specifically geared toward time off for caregiving outside of what's required by law. But generally, you know, we're really flexible and work with our associates as much as possible. So
with the benefits supporting the responsibilities, I know that flex time is really important for employees, whether you're in the caregiving role or as a survivor. So both of those are important. And also the use of paid or unpaid time off. Do you, Joanne, do you have policies in place at City of Fort Worth on the paid leave or unpaid time off?
We have so we offer obviously FMLA like everybody else does. We have a very complicated leave system that is actually in the process of being changed, where we offered, of course, we've got vacation pay, you know, like everybody has. And then for our general employees, not our civil service folks, not our fire or police officers, we have this thing called major medical leave, which you can only touch in the event of a major medical situation. It's not short-term sick leave. It's not anything like, you know, if I just needed to take the day off for the flu, you have to be out for more than 56 hours. It's this whole thing. And so we have a lot of employees who have a lot of that built up because we've got a lot of long-term employees. Unlike a lot of other kind of industries, sometimes our folks will start here and stay 25, 30 years just here at the city. So they can build up 1,000, you know, 2,000 hours of this major medical leave that they can only use for a major medical situation. So we do have that available to them. We're in the process of changing that major medical leave to be a true sick leave, because one of the problems with our major medical leave is that it's for only the individual. So it wouldn't support caregivers at all, because if I needed to take time off, you know, to care for my spouse or my child with cancer, I wouldn't be able to use my major medical leave. I'd have to burn vacation for that. So we are changing January 1st that this major medical leave, excuse me, the accrual rate will be the same, but you'll be able to use it for anybody. So if I needed to take time off for family members, I'd have that ability to do so.
Mm-hmm. Okay. Yeah, that's great. It sounds like you're tuned in for that pretty well. So Rita, thinking about your work at the City of Garland and caregiving, can you kind of describe how you're approaching those who are in either the caregiving mode or even the cancer care patient mode that also is in need of caregiving? Do you see, Rita, when you're working with employees in that regard, any insights about that? What could be done better?
Well, I personally know. I'm sorry. I personally know about sick leave. My mother lived with me. She had Alzheimer's, and so there were times when I would have to take family medical leave. So I was able to do that, and also I could take my sick leave as well to take her to the doctor. So I can't remember the person's name from the city of Fort Worth. And yes, and so we do have employees with lots of years of service, and so you can have a lot of sick time, and so you can use that with, you know, getting approval from your manager.
Let's talk, we in the video presentation, we learned a little bit about advanced care planning and how important that is and how employers can really support that. It turns out that 1 in 5 employees have some type of advanced plan. That's only 20% of your employees have some type of advanced plan in place or a living will in place. And those that have a workforce of younger people, the millennials and say the Gen Z employees, they may need greater education about advanced planning because, you know, they're the invincible ones. They don't even think ahead of that. whereas your older population, workforce, may already be thinking about that. So, for example, just for all of you participating in the employer roundtable, you can just chime in. Does your company cover hospice care? That would also, they probably would help you with advanced planning or any type of advanced planning advice.
We definitely have hospice. We have unlimited hospice. We do cover like medical equipment at home. We're coordinating. We're rolling out some new coordination programs between our medical and pharmacy programs to coordinate the pain management process and stuff like that as well. As far as, I'm trying to think of other things that we do. I mean, we basically provide our employees a business program that's very robust. We have work-life concierge services as well. So if you need to find somebody to help you take care of someone, we actually provide those services free to all of our family members, regardless of whether they're covered under any medical plans or not. We've got 46,000 people that have access to a concierge program to help them find services and respite care and stuff like that if they need it. As far as our time off, we don't really do a whole lot in that respect, being retail restaurants. But it is, it's one of those things that when we do have a situation where we have to send people home, we did create some emergency pay for the quarantine situations and stuff like that. So we've done everything that we can to try to make it as uncomplicated as possible. But from the cancer side of the house, we're very sensitive to it. We have a number of long-term, we call our employees family members. They have a number of long-term care members, and so we try to make sure that we route them into the right way to get as much care as we can. Reaching them is a problem for us, quite honestly.
That's very helpful. Thank you for sharing all that. Anyone else want to chime in on that?
Yeah, I'll add that we do have, typical EAP services that we promote to all of our associates, so they can definitely use that resource to find, an attorney who can help them with advanced directives. We probably don't, get as much participation and engagement as we should. We have a hard time just getting our employees to name a beneficiary on their life insurance or their retirement plan. So it is a struggle. We also have an actual benefit that's company provided. It's just for our director level and above, that we actually, through our executive life insurance, there's a free will planning advanced directive benefit. But again, it's to the higher the executives, but our EAP, yes, is able to help people with resources. But again, it is hard to get engagement with that. So.
This is Rita, and we also have an EAP program through our Aetna. It's called Aetna Resource for Living, and it provides some legal services, but we do have a separate legal service that employees can choose, ARAG. And also we have our Compass program as well. I think the new name is Alight. So we have quite a few services for our employees.
That's great, Rita. Thank you. And Joanne, were you going to also chime in?
We have pretty much the same. We do have high utilization on our EAP. We do offer prepaid legal through one of our voluntary benefits. And then we currently have Alight. We're switching over to Accolade in the new year, who kind of do a lot of the concierge stuff. So they would be able to help with that. And then, we do have our own health center. So that is something that if in the future we feel is warranted, we can have our health center add that, request to our health center providers for those of our employees that go to the health center to kind of start having these conversations with members. Although I say that, and I went to one of our health center providers to have that conversation, and she seemed puzzled why I wanted to, because I guess I'm not in the appropriate age bracket in her mind. But, it is something that we do have some support available for it. It's not a comprehensive by any means, But there are resources available.
Right. Very good. So it's not, this is something that sounds like many of our employer members are tending to. Teresa Williams, I don't know if you're able to chime in or not. I know that you're having some difficulty with the microphone side of it, but if you can call in the number, we could tune in with you somehow. And I'd love to get your perspective on these as well. Okay, so Teresa, we're not able to chime in, but if you can, we're waiting for you. One of the things that I wanted to mention, when we talk about survivorship, we've talked about caregiving a lot, and caregivers and those who are given who receive. The number of cancer survivors in the US is growing rapidly. From in 2019, just last year, it was 17 million. They estimate in just another 20 years, it'll be 26 million. And that's thanks to early diagnosis, all the screening tests that you offer and at work, and the encouragement you give your employees to do that, and more precise and more effective chemotherapies. That's just really great news for a lot of people. Like right now, 2 out of 3 cancer patients have survived more than 5 years. About almost half have survived 10 years or more, and a few have survived maybe less than 20% for 20 years or more. This is great news, and these are the people who stay in the workforce and they want to go back to work. And so when we think about the type of cancer, the cancer care journey that they're embarking on, whether they're cancer-free or not, or still in treatment, one of the things that I think is really important is the handoff from the oncology team that is probably working hard to manage everything during the treatment. But what happens when they go back to the primary care physician? So can we talk a little bit about what your thinking is, or if you have any strategies in place to make that handoff more efficient, more effective, and more supportive of the employee who may be frightened even to leave the oncology, I guess, the cocoon of health that they have, intensive health. Any thoughts about that? This is something that I hadn't thought of myself, but now that we focus on the primary care so much for early detection and management, how does your health plan help bring these two together, the oncology and primary care? Any thoughts on that, anyone? Or maybe the question is, have you even thought about that connection with the primary care for those who are survivors?
Well, I can jump in and just share my experience, which was that there was no coordination whatsoever. For me, I was, the oncology said, here's what your follow-up schedule is going to look like for the next year. And that was it. There was no discussion of should I, make an appointment with my primary care doc to discuss things, or there's no talk of that whatsoever. So I was just on my own.
Thank you, Julie. This kind of brings us to the question, how could it work better? How could a benefit strategy ensure that coordination between, or even communication between the oncologist and the primary care? Because we're really trying to offload a lot of the specialist work and a lot of the primary care to the primary care physicians. And what's the role of the health plan? Can they be helpful? Julie, what do you think about that? What could happen?
Well, I know there was some discussion at one point within the Medicare system to pay for a transitional visit that that your primary care doctor could bill for. A transition from treatment to surveillance visit. Now that didn't actually pass, and so that doesn't actually happen, but there was some discussion about that, and there were some nonprofits who were advocating for that, because the transition can be critical. That's where the ball gets dropped a lot of times, and so the patient just doesn't see anybody. They just go back to work, they go back to their regular lives, and sometimes things can be missed because they didn't know they needed to talk to their primary care doctor about the changes in their body as a result of treatment, anything like that. So it would be great if insurance companies, Medicare, Medicaid, would pay for a visit like that. It'd be billable for the doctor.
Thank you for the insights on that. Just thinking about that, Joanne, I saw your microphone on. Do you mind talking a little bit about how is this a challenge, and do you see any ideas or insights on how we might address this to help other employers to be thinking about this? Because again, I hadn't thought about it, but I'm not in that space.
Well, we're hoping that the Accolade, our new Accolade model, will be heavily involved in that kind of coordination, because that's one of the things that we're basically hiring them to do, is to do a lot more of the coordination between with a significant health situation. All right, here is what you're supposed to do, or here's how you handle it. Here's what you need to think about. Here are the kind of doctors that you would work with. And since they get their own assigned health assistant, and they all have nurses behind the scenes to help our employees who are struggling with these kind of scenarios figure out what the right place to do is, or what the right answer is.
Mm-hmm, mm-hmm. So, yeah, thank you for saying that. And I know that a lot of companies are looking to a third-party vendor, as we call it, an Accolade or another navigator service. And it's a shame that all companies would be required to do something like that, because isn't it in fact something that perhaps your health plan should be helping with as well? So I don't know. What do you think, Rebecca? Do you think the health plan has a role in this?
Yeah, I mean, we're looking at the same thing. We're looking at a third party point solution to help. I will say, not to give a plug for any particular health plan, although where credit is due, you should give credit. We do have Kaiser plans in the regions of the country where Kaiser is predominant. And I will say they do a really, really good job with care coordination, cancer care, working with integrating care, because it's all under one, just kind of by definition, the Kaiser system is coordinated because all the doctors work for Kaiser, all the cancer. Mm-hmm. So, and, we think the quality of care is excellent with Kaiser. So, not to say that model should just be duplicated, but that we do, we know it can be done, right? Because Kaiser does it. Yeah. So yeah, it is kind of a shame that you have to go out and look for a third party to help, but that's, yeah.
Mm-hmm. Yeah. And that's not to take away from the wonderful services that the third parties offer. They moved in where the need is. And so that is, we definitely appreciate that. Teresa, I see that you've been able to tune in. Can you chime in on this issue? Okay. Rita, you were going to speak.
Okay. Yes.
Hi, Marianne. This is Teresa. Can you hear me?
Yeah, now we can. We can.
Not the third time, but maybe the 10th time is a charm, I guess, with this case. I apologize because I did try to respond a few times, but one of the things I'll mention is that we are in the same situation where we're looking at a third-party vendor next year. And like you said, you would hope, and maybe in some of the earlier days you did get this from healthcare, your healthcare providers, but we are in the same situation where we're evaluating different vendors for that kind of concierge services, second opinions for LBIT starting next year as well. So we're just starting that evaluation right now.
That's great to know. And Rita, how about you?
Okay. Our providers always tell our employees when they finish their treatment, they need to come back to us. And so we have a high return. One great thing is there's no out-of-pocket for their care here at the clinic. So it's really incentivizes them to, return back to their primary care, which is the city care clinic.
Okay, thank you. We're almost out of time, and I have one last point that I really want to talk about just briefly, and that is the cancer cost management. I thought it was so interesting about that oncology model for Medicare's oncology payment model, how it really was business as usual for the managing cancer care on the provider side, and that was a little disappointing. So I can understand the reasons for what they presented in the video presentation, why it's so difficult. Every case is different. There's just not uniformity, and lots of challenges for getting some kind of a bundled payment. However, there are things that employers can do. For example, a high performance oncology network. Do any of your companies have in place through your health plan or direct contract with something like centers of excellence for oncology, or a set of community alliance oncologists who work together and coordinate care? Julie, do you have anything in place like that to manage the care? Julie Tatum?
Which Julie are you talking
Yeah,
to?
which Julie you want?
Julie, I'm so sorry. Julie Tatum with our Whataburger. Thank you.
We don't. We are looking into it. I haven't, I'll just tell you that, with COVID stuff coming in, we just kind of put everything on hold that we were going to look in for major changes for the next year. We've done everything we can. But we are definitely looking at that as to, potential centers of excellence. And, we already have some COEs for surgical sides of it, but I want the ongoing patient care as well. And that's hopefully.
Great. Joanne, how about you? Do you have something in place, centers of excellence, high performance networks, or some?
We do have it through United Healthcare. We have centers of excellence that are covered with our UHC plan. I don't know how much. I don't know how much they work or what their, the ROI is on that, but we do have them.
Okay, that's helpful, encouraging. And Teresa, what about you? Does Elbit, for your Elbit employees, do you have a center of, do you work with your health plan for oncology, high performance, high quality network?
We do have centers of excellence, but not for, we don't have those in place for cancer.
Great to know. Let's see, who else? Rebecca, what about you, and any special networks for oncology?
Yeah, just whatever the carriers offer. I think most of them do have centers of excellence for cancer care. So, and I know this wasn't your question, it was more about employer costs, but we did implement, as far as, the cost to the employee, we did implement an option for critical illness and hospital indemnity insurance this past year. Our year's mid-year, in the middle of the year. So we're too soon to tell, but we did have a pretty good participation. It's a voluntary plan, but it helps pay for out-of-pocket costs for such things as cancer. So we'll see how that goes. Yeah.
Okay, thank you. That's good to know. Teresa, were you going to chime in on something?
Yeah, I was just going to say we put them in a couple of years ago, hospital indemnity, critical illness, and accident, and we had really good participation. We continue to. I'm very pleased with the providers. I think we had probably between 25 and 30%, again, all voluntary benefits that aren't paid for by Elbit, but very good participation in those.
Right.
Yeah, and I was really impressed with, I know this is standard in the industry, but we hadn't offered this before. So, each of the carriers for all the critical illness, the hospital indemnity, they all have a wellness benefit as well. So, you get $75, $100 a year to, go to your primary care doctor or get a cancer screening or whatever. So it's kind of an extra incentive, to emphasize the preventive side of things as well. So we think that'll be beneficial.
Okay. Joanne, were you going to make a comment?
Oh, no, I mean, we have the same plans and we've had them for quite some time. So that is a benefit that's out there and available for our folks as well.
Okay. Well, we're just about out of time. I've got 1 minute left, so let me use that time to thank all of you for participating in this roundtable discussion. It's been just very, very informative, and I think the next step is to go for our employers and those who are listening in and participating in this, to go back to look at your cancer care is is your highest cost, unless you've got a hemophiliac or some prenatal problem, but cancer is prevalent and is high cost. So it's worthwhile looking at some of these strategies. And as I said, we have the access to this roundtable discussion, and which is being recorded. And for all of you who have participated, we will make sure that you get the link to it, also to the presentation. And we know that employers are, the studies have shown, recent Gallagher studies show that more than 60% of the employers anticipate a much more aggressive oncology management in 2021. I assume that that's going to be the case in the Dallas-Fort Worth for our employers and across the state of Texas Business Group on health employers as well. So that's a good thing, and the challenges are there, but use this information, the video presentation and the discussion that you will have access to help you kind of fine tune or focus your efforts, because there's a great need out there, and you are in the driver's seat on cancer care management benefit strategies. So thank you for listening in. Thank you all for being part of our 2020 Cancer Care Symposium and going with us on the cancer care journey to try to solve some of the problems that our employees meet along the way. So thank you, and thank you, Julie Coates, for being part of this as well. Have a great, wonderful week and a wonderful Thanksgiving, COVID-free, safe, and a happy time, if you can, with family, whether it's Zoom or socially distanced in person. Thank you all.
Thank you.